Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. We're so happy to have you all here tonight with us live, either through Facebook or YouTube, wherever you may be. Welcome, welcome, welcome. Tonight, as many of you know, we will be talking about some of the exciting advancements in early stage lung cancer. We have an all-star cast with us tonight to discuss what's going on in that space. But before we get into introductions, I want to talk a little bit about the living room for those of you who may not be familiar. Maybe this is your first time. So I'm Danielle Hicks. I am Chief Patient Officer here at GO2 Foundation for Lung Cancer. And this meeting is set up as a support and education series that we crafted specifically with patients and caregivers in mind. The aim, of course, is to help to facilitate these educational talks from, as I said, folks like we have on our panel tonight, key opinion leaders. And our aim is to do it in a format and in a language that the layperson can understand. I know a lot of us in the lung cancer space spend a lot of time on Google, and quite often things that you find on there, Dr. Google and other places, are really hard to understand. A lot of them are written at a very high level, primarily scientific papers. So we really try to get that down into a language that makes sense for everyone. And we are here for all lung cancer patients, regardless of type, regardless of stage, whether you're currently in treatment, whether you are no evidence of disease, whether you have relapsed, we're here. And we hope that you get as much out of this as we get in bringing it to you. So thank you again for joining us. As I said tonight, we've got two amazing physicians here. One is medical oncologist extraordinaire, Dr. Osarogiagbon. He is from Baptist Cancer Center in Memphis, Tennessee. And we have Dr. Jones, who is the Chief Thoracic Services Department of Surgery at Memorial Sloan Kettering Cancer Center. It's a tongue twister every time I say it. And I'm going to, as those of you who watch this know, I like to let our panelists give a little introduction of themselves to tell you a little bit about who they are and why lung cancer became an area of focus for them. And I'm going to start with Bonnie, who I know for most of you needs no introductions, but I'd like her to tell us a little bit about who she is, and then she has a special shout out to someone I think she was speaking with earlier today that she wants to give a little message to. So take it away.
All you need to know is that I'm a very happy 15-year lung cancer survivor, stage 3B, with a tumor on my aorta. You're a surgeon, so you'll know what that kind of meant. There were 3 surgeons after I had a lot of chemo and a lot of radiation, and I wasn't. It wasn't clear that I would still be around. And I promised myself, if I was lucky enough to make the cut, that I would do something to change all of the things that were standing in the way of lung cancer being either a chronically managed or a cured disease. And I'm just thrilled that, we're on our way. When I say we're on our way, I mean all of us. And, my shout out is for a brand new friend of mine who I've only known for about 6 weeks, I think. Her name is Catherine. She lives in San Francisco. And somehow she found me, and I was able to help her get to the right people up there. And she called me today and said that after being on the right therapy at the right time, her tumors are almost indistinguishable. So we're all really excited for her. And I love you, Catherine. And mwah.
Thank you. And just on that note, before I move over to Dr. Jones, I would also like to give a special shout out to the beautiful lady that was just talking. Most of you know that she is my mom, and I am her eldest daughter, which my younger sister likes to make sure everyone knows. Speaking of that surgery, and how far she's come since then. Tomorrow will mark 17 years since that surgery and since she has been cancer-free. So a huge, huge shout out to her, and not only for getting through the whirlwind that you got through, but for standing up and making a difference, especially when you didn't have to. You could be sitting on a beach somewhere. So thank you, thank you. Dr. Jones, will you do me the honor of introducing yourself and also maybe talking a little bit about you and Bonnie being co-chairs of a very special Corey grant?
Yeah, thank you so much. It's my honor to be here tonight. It's a fantastic session. I'm very much looking forward to it and looking forward to learning about it. So I run a group of 12 thoracic surgeons at Memorial Sloan Kettering Cancer Center in New York, and our goal is pretty simple. It's just to try to cure lung cancer. And we focus on that in a number of different ways, primarily through a lot of clinical trials and a lot of research. And we have busy practices. We see a lot of patients from all over the world, but every patient's different and no one's the same. And that's one of the things that drew me to oncology. And I think that when you sit down with someone who's got cancer and you hear their story and you hear what they're going through, I just felt like it was something I wanted to be a part of. And I really enjoyed the research aspects of cancer and how cancer is complicated and how we have to really think outside the box to try to cure it. So that's kind of how I came to lung cancer and to thoracic surgical oncology.
Fantastic, thank you. Dr. O, I'm moving on to you.
Yes, good evening, everyone. Good to see you again, Bonnie. Thanks, Danielle, for inviting us. Good to see you, David. My name is Ray Osarogiagbon. I'm a thoracic medical oncologist at the Baptist Cancer Center in Memphis, Tennessee. I got into this sideways. I actually did a fellowship at the University of Minnesota in hematology and oncology, but my interest was actually in hematology. I had come in as a young man to do postgraduate medicine in the United States, and I wanted to go back to my native Nigeria with some unique marketable skills, and I thought the area that would be really valuable would be sickle cell disease because there was a lot of it in Nigeria. My mentor as a resident said, well, Ray, I know you want to go back to Nigeria. You do a 2-year fellowship in hematology, go back, but you never know what life holds. Please do me a favor, diversify your experience, take an extra year, do a hematology and oncology fellowship, and you just might find that, that's good advice. I took it grudgingly, and then after that, my family circumstances changed. My wife was stuck in a hospital bed for 4 months with our twins, who just turned 22 years old, by the way, on Thursday. And that changed everything for us. I wound up going to the VA in Amarillo, Texas. I was supposed to stay there for a couple of years, go back to the lab I'd worked in. But as I stayed around in the VA, there was no sickle cell disease, but there was a lot of lung cancer. And I got curious about that, curious about why things were the way they were, why we missed so many opportunities within the VA, where you had the benefit of a really good electronic health record system at the time. This was 20-something years ago, uniquely at the time. And so you could go back in time and see just how many opportunities did we have to diagnose this thing and act on it that we didn't quite carry out. So I got into this idea of bringing all the disciplines together up front to make decisions on patients. The Inspector General came and looked at our VA and said, oh, that's an exemplary program, needs to be done everywhere. And just as my head was getting inflated, people reminded me, look, Ray, my work in the VA never worked anywhere else, so don't get your hopes too high up. I thought, well, that's interesting. Where does lung cancer really, really prove to be a challenge? Well, it's in the Mid-South, Kentucky, Mississippi, Arkansas, Tennessee, these parts of the country. So I came out here to Texas at the University of Tennessee, and then wound up ultimately at Baptist, where I've been able to continue a lot of the research that I was interested in. A little long story, but a little bit of a roundabout way to get to here.
That's great. Thank you all so much for all of your words. I want to remind everybody before we jump into the program that some of my amazing colleagues are online. So if you do have a question that you would like to ask of one of our panelists tonight, please put it in the chat and they will get it over to me, and I'll be sure to try to fit it into the program. And with that, we're going to jump right in. We've got a lot to cover and not a ton of time to cover it in. So before we jump into things, I guess one question I'd like to ask is what actually constitutes early stage lung cancer? Is it 1, 2, sometimes 3? Like what constitutes early stage lung cancer? Anybody?
Dr. Rai? Go.
Defer to the surgeon first.
I think we think of early stage lung cancer as typically localized to the chest, to one of the lungs, and only one. And we think of it being as more of a discrete nodule. And typically, at least by imaging studies like CAT scans and X-rays and PET scans, there's likely not any lymph nodes involved. And so that would be an early stage tumor, relatively small, like less than 3 centimeters, no lymph nodes by analysis, and all contained in one area. It's not moved outside of the chest, it's not spread anywhere. So I think that's what I think of when people say they have early stage lung cancer.
And more often than not, these patients diagnosed early are surgical candidates. So I want to jump in a little bit to talking about those patients who are surgical candidates, and start really with the different types of surgeons that work in the chest and or on the lungs, and why it's important for a patient to know what type of surgeon they have and what questions they should be asking. So Dr. Jones, can you talk a little bit about the different types of surgeons that might perform a lung cancer surgery?
Yeah, that's a great question, Danielle. I think there are a few types of surgeons who operate on lung cancer. I would say there's occasionally still some general surgeons. These are surgeons who have some experience operating on lung cancer, probably are a little older and have not had formal training, but have some experience. And they still do a fair number of lung cancer surgeries in the United States. Then there's the cardiothoracic surgeon who also does open heart surgery, but may as well, in kind of a mixed practice, also do some oncology work, some lung cancer surgery. And then you have a more dedicated thoracic surgeon, a thoracic surgical oncologist, even more so, who that's all that they really do. They're very focused on that disease, and they're very focused on working as a team on managing that disease. And they tend to have, I think, a little more experience, because that's all they do. They're not also taking out an appendix if you're a general surgeon, or if you're a cardiac surgeon doing open heart surgery. So those are the 3 types of surgeons that tend to do lung surgery. And I would say that hospitals in general are moving towards credentialing surgeons who are dedicated thoracic surgeons for their oncology programs, for their cancer centers. So I think that, and that's for reasons that are pretty clear. There's a fair amount of data that outcomes are typically better when you see a thoracic surgeon, and that's what they do most of the time.
I think that's great. And I think it's really important to point out given that, upwards of 40%, I guess it depends on what paper you're reading or where you're getting your data, of patients, regardless of an early stage diagnosis, will recur, right? And so I think that one of the first steps is really knowing who's doing your surgery, how many of them that they have done, and what their sort of track record looks like, because it is sort of the first step in coming out the other end with a successful curative outcome. That's just my 2 cents. So with that being said, before we get into some of the advancements, historically, how have these early stage surgical patients been treated? What does that look like? And can you talk a little bit about not just the surgery itself, but sometimes maybe patients have treatment before, sometimes they have it after. What does that look like in this patient set?
The first thing that any oncologist, whether a medical oncologist or surgical oncologist, needs to do is establish the stage of the cancer. And to do that requires typically some imaging studies. I mentioned earlier, a CAT scan, a PET scan. And we have to get a tissue diagnosis. Is this really a lung cancer, or is it something else? Is it a benign process, something that's mimicking a lung cancer that we would treat totally differently? And that often requires a biopsy in order to know what it is, a pathologic, referred to as a pathologic diagnosis. And then you finally begin to put together what type stage they have. And let's say it's an early stage cancer where it doesn't appear that it's spread to any lymph nodes. And then you really need to assess the patient, what's their physical abilities, how functional are they, and could they tolerate an operation? And if they can, then typically surgery is the first line approach. If you look at, guidelines for which all surgeons should know about, that would be the first approach, provided the patient could tolerate that operation. We would not generally give treatment like chemotherapy or immunotherapy or targeted therapy for very early stage tumors, because there's no proven benefit yet that would be helpful. And in fact, at least for chemotherapy, it's harmful. So we would not do that for a stage 1 lung cancer, for instance. Now, having said all that, the tumors are not always only 2 or 3 centimeters. Sometimes they're bigger, and sometimes they have some lymph nodes that are involved, either by biopsy or by PET scan. And in those situations, they're not just early stage. These are what we call more loco-regionally advanced. They're a little bigger. They may involve lymph nodes. And these patients may, in fact, be candidates to get some treatment first before you would consider an operation. And increasingly, we're making decisions about what type of treatment that person should receive before an operation based on information from the biopsy. And here we're talking about specific aspects, features, characteristics of the tumor, such as the tumor genes that are there. There are also if there are certain proteins that are expressed that may make the tumor more susceptible to immunotherapy. So we're getting more and more information from the biopsy, and those patients may get some treatment. Typically that lasts maybe, 10 weeks, 12 weeks, and then the patient gets an operation. So, and we can talk more about what happens after an operation, but I think that at least gets us started on your question.
That's great, and I think Bonnie can talk a lot about what happens after an operation from a patient perspective too. So
the one thing thing I would make one comment about is just on the approach. I would say that heretofore surgery was commonly done in the 1980s, 1990s with a pretty large incision in between the ribs, but almost uniformly now, I would say 80% of thoracic surgical operations for certainly early stage lung cancer are all done minimally invasively now, either with a video assisted or sometimes called BATS approach or robotically. And so I think that that has been a real benefit for early patient recovery, less pain, and I think it's really seen in the early phases of recovery. After about 6 months, whether you have the big incision or the small incision, it doesn't matter so much. But getting you home and getting you back to work and getting you back to how you want to be with your spouse and your family, the minimally invasive approaches, I think, have made a big difference.
And I think that points directly back to what you were talking about earlier when you're talking about the skill of the surgeon, right? Because not just anybody can use a VATS or a Da Vinci robot or something like that, right?
Exactly, and particularly for the more complicated procedures. So I think that as your experience grows with those approaches, then you realize that you can do more things, you can do them well, just as well, and perhaps even better than the larger incisions or the open approaches.
That's great. I have a question coming from the live audience that I think is okay to ask right now. I think it's appropriate. So this patient has a ground glass opacity, very early stage 0. They haven't yet diagnosed it as a stage 1, but they're worried. What does the follow-up, or what should the follow-up look like in a patient like that? Or potential patient.
Can I ask, can you communicate with the person? Like, is the person
a smoker? They can hear you and they can get back to me.
Smoker or non-smoker?
We'll wait on the answer and then go ahead.
The reason I mention that is probably, at least in my practice, somewhere between 25 and 30% of patients who have lung cancer are lifelong never smokers, or maybe had a few cigarettes in college, something like that. And they often present with these ground glass opacifications, or what I call a little smudge on the CAT scan. And how you treat those is typically you do not take the patient right to the operating room. We really want to try to avoid over-treatment in these situations. And it's best here's where you really need to see someone, a pulmonologist, a thoracic surgeon who's very familiar with this, who works carefully with the radiologist. Sometimes these smudges can become more solid, and as they become more solid, then there is a concern about an invasive lung cancer. But oftentimes, these lesions can just be managed with what we call active surveillance, which just means they need serial CAT scans, careful follow-up, and there's nothing that they need to do emergently, including not even getting a biopsy. Just need to follow it very carefully.
Yeah, I think it's. I'll just jump in and chime in that the reason why what David just said is very important is that as we are doing more CAT scans, radiologic imaging, we are finding a whole lot more people with these things. And the challenge is, if we pull the trigger on everybody, jumped in and flailed around, we would probably hurt more people than we would help. So it's very important to understand that most of the time, these GGOs, these ground glass opacities, are actually very indolent, even if they're cancerous. And there is I think about a third of them actually resolves continuously. Turn out not to be cancer, just a little, inflammatory something that looked like a cancer for a while. But even the ones that turn out to be cancer, so long as there's some judicious oversight, the idea that you missed a cancer diagnosis for a little bit of time does not come back to be harmful. Therefore, we do have time to watch them until they Sometimes these things, they play possum. So you do have, now the Fleischner Society recommends that we actually follow these patients for at least 5 years. Because sometimes they play possum on you, but so long as they don't change the way David said, become more dense or get bigger significantly, it's actually safe to watch them.
That's great. Can you, I just want, and then hold that question 1 second, because you mentioned Fleischner's, and if you could just explain for our audience what exactly that is.
Yeah, the Fleischner Society is an international society of people very interested in conditions within the chest, especially the lungs. It's a society that's was made up traditionally mostly of radiologists, but X-ray specialists. But over the years, they have expanded to include, mongrels like myself in medical oncology. There are surgeons. There are lots of pulmonologists in the group. They make guidelines for diseases of the chest, including, in this case, what we're talking about, how to manage lung nodules in ways that are both safe and effective. So we don't do basically exactly Goldilocks, trying to make it where it's not too hot, not too cold. We don't sit on things that can become dangerous, but we don't jump in when it's something that could really be left alone.
Thank you. I just wanted to make sure that people...
Fleischner guidelines we talk about that we revise every so often. Yeah.
Right. Yeah, I just wanted to make sure people understood what you were talking about when you were referencing it, and that there is a process in place, whether it's Fleischner or, lung rads or something like that, where people are looking to not, to your point and to Dr. Jones' point, aggressively going after something that might not even be a cancer. Mom, go ahead. You had something.
I have a question for both the doctors. And maybe this is too early, and maybe I'm jumping in too quick on this particular issue, but it's one that is really close to my heart, and that's multidisciplinary teams for patients. And we've already talked quite a bit, and patients are listening, and they're confused, and they stay confused, too often for too long. When do we tell patients to get a second opinion? And sometimes we have to kind of force them, in that direction when we kind of see what's happening or not happening that should be happening. But what are your thoughts on decision making and multidisciplinary teams?
Maybe I'll take that to lead off. So lung cancer is complex. It is very, very complex at multiple levels. The patients, to begin with. Patients tend to be somewhat older. They tend to have accumulated other comorbidities, whether heart disease, stroke, even a previous cancer. The place we're worried about, the chest cavity, is anatomically hard to get at, okay? It's got all these bones. It's got the heart in there. It's got these big blood vessels. And of course, the lungs are nothing more than inflated balloons, just daring you to pop them. So gaining access to the thoracic cavity, turns out, is a challenge in response to which all kinds of innovations have happened. And each of these innovations tend to be controlled by a different type of doctor. So when Dr. Jones talked about getting a biopsy, for example, there are many different ways you could do a biopsy. It could be simply a radiologist using a needle. It could be a pulmonologist using a flexible tube. It could be a surgeon actually taking you to the operating room to take a piece of something. Staging treatments, surgery, radiation therapy, chemotherapy. And the nice thing with lung cancer is the challenge is getting even more complicated because our options are rapidly expanding. So it gets to be very confusing. And the truth is, in human systems, no one person can honestly master this widening array of options. So what do we tend to do as humans? Well, I got a hammer, so everything becomes a nail. If that's all I know, chances are I'm probably going to offer that specific service. Maybe what the patient needs may not be what the patient needs. So the idea that you have a complex, scary, and yes, indeed, still often lethal problem that is difficult to manage, and that management involves many different people, some of whom may or may not be needed in any individual patient, creates what? A need to communicate better, transparently, upfront, early among ourselves, which is really what this multidisciplinary idea is. So when the question comes, should I get a second opinion? My answer is, of course you should. Are you kidding me? This is a life-threatening challenge, potentially. And when the question comes, where can I get such a second opinion? Well, the nice thing about multidisciplinary care is that if you think about it logically, it is actually a second, third, fourth opinion, because you have the surgeon, when done right, you have each of these many different specialists in the room together around you, virtually or in reality. You got surgeons, you got medical oncologists, you got radiologists, you've got the pathologists, you've got the pulmonologists, you have palliative care people. So when one guy wanting to be over eager to do his thing maybe seems to be getting out of line, you have all these other partners who can come and say, whoa, have you thought about it from this angle? Have you thought about this? And then at the end of the day, when done right, they actually gather together and then arrive at the best evidence-based consensus for that patient within the limits of what the patient is willing and able to accept. So the other thing we must not forget is ultimately it's a shared decision-making thing that actively involves the patient and ideally their caregiver as well.
Thank you so much. Dr. Jones, did you have anything you wanted to add?
No, I think Ray did an outstanding job really talking about how important it is. And I think we've increasingly appreciated that a team approach to whatever the disease is, whether it's heart disease or some neurocognitive problem, and certainly cancer, the outcomes are actually better for the patients. So I think that whenever possible, you should be getting a multidisciplinary. And what does multidisciplinary mean? It means maybe you should be talking to a radiation oncologist and a medical oncologist and a thoracic surgeon. And the really cool thing is, and one of the things that we've realized in the pandemic is, you don't need to go see all of those people yourself. That can happen virtually, and it happens on emails, and it happens on phone calls, and it happens when doctors are really focused together and are communicating, as Ray said. So I think that, the burden's not on the patient to go to all of these appointments. I think the burden's on the doctors to make sure that they've done a good job running this case up the flagpole, if you will, and making sure they've looked at all options.
Yeah. And, we've talked a lot around here and, even outside here about the silver linings from COVID, and Zoom calls is one of them. What you just said about telephone calls or this or that or another, look at us. We're sitting here. There's 5 of us, and we could be the multidisciplinary team, all looking at each other, and we could be putting up the scans for everybody to see the same scan and the same biopsy results and the pathology. Think about it. It's revolutionary and not necessarily done that way. And you can actually bring in physicians from other hospitals and other disciplines, so just the doors are open wide for us to just be so much more creative and so much better at what we do using technology.
Yeah, I agree. And I think it's really important. It kind of circles back to Dr. Jones, something you said in the beginning about all patients are different. No, there are no two patients alike. And lung cancer treatment is not a one size fits all, sort of decision-making process. And so having this team of experts within their own fields of expertise, whether it be thoracic surgery, medical oncology, radiation oncology, pulmonology, pathology, I mean, you name it, right? Having all of those minds together, I know from experience and talking with patients, is a comforting thing when they know that they've got a multidisciplinary team meeting at tumor conference or tumor board or whatever you want to call it, wherever you are. They feel good about the decisions that are being made because they know it's been well thought out. So I'm glad that this came up as part of the conversation. I want to jump back because I'm trying to be mindful of time. And I want to jump to advancements that have been made in this early stage setting. We touched a little bit on, or Dr. Jones, you did a little bit on determining whether or not we're going to treat a patient, before surgery or after surgery. And some really exciting things came out at ASCO last year around the Addario trial. Can you talk a little bit about what that is and what that means for patients that are diagnosed at early stage?
Yeah, I would just echo, I think, what someone said earlier in our conversation, that 30 or 40% of patients who have early stage lung cancer have a recurrence. And one of the advances that have been made is our understanding of what we call tumor genomics. And there are certain genes that if they are altered, sometimes you hear the term mutation, that means they're altered, that they can actually have drugs that begin to target that alteration, and those tumors respond amazingly well to that targeted therapy. And what we found with a specific gene, an EGFR gene, an EGFR, if that gene is altered in two specific ways, patients who have their tumor removed, and that gene, again, this is the gene in the tumor, not the gene traveling, not your own genes. This is the tumor gene. It's so important to know that. But if your tumor has that alteration and you then take a pill, as well as some chemotherapy at first, but a pill ultimately, after your operation, the likelihood that you are going to have a recurrence, at least in this multi-institution phase 3 international trial, was about 87% less than those individuals who had the same alteration but didn't take that targeted pill. And also, one of the challenges with lung cancer surgery is that sometimes it can recur, and it can recur in the brain. And so at ESMO, which is another big medical conference in Europe, the observation was made that the recurrences in the brain, which are very tricky to treat, were also much less when you were on this medication. And so I think these are this is an example of the advances that Ray mentioned, all of the things that are now coming and before us all, how to treat lung cancer in its many phases. Is that there are now targeted therapies. And so it's no longer going to be perhaps surgery only. There will be possibly a pill or other therapies that add real benefit. And this is not dissimilar to what we see, for instance, in breast cancer. So I think lung cancer is moving in that direction. And it won't just be pills. There will be immunotherapy. There will be other approaches. So even for early stage lung cancer, and let's just put early in quotation marks, it's likely that it's going to require a multidisciplinary, a multi-pronged approach for us to maximize our outcomes. And so that the name of this trial that we're using as an example, as a paradigm to discuss the evolving management of early stage lung cancer, was called the Addario trial. And I think Ray should comment on this, because I think there'll be more of these types of trials.
Yeah, David, I think that's a very good point. So there is a general pattern that drug discovery works in. When a new target is found or a new potential treatment is identified and the drugs are developed to test, typically, ethically, we would start from the most difficult end of things. Patients who have pretty widespread condition that is not regarded as curable, that have already undergone and maybe seen multiple types of treatments tried and not succeed. And then those patients go into trials to develop these drugs. Now, once these drugs are proven, typically they're proven in people first, second line, after conventional first line treatment has failed. Then if the drugs are promising, we begin to ask, well, gee, is this drug as good, better, or worse than our so-called current standard? Now, once it passes with these advanced stage conditions, we begin to ask about bringing the drug closer and closer into earlier and earlier stage, where we know we still, in spite of our best efforts, continue to struggle to cure everyone, which is ultimately our goal, to have lung cancer go away and never come back in everybody. So when we have drugs that work, that clearly work, oftentimes have been approved to be used in for patients whose condition is more advanced, then we go to people whose condition does not look that advanced, but in whom we know we're not perfect in achieving a cure, to ask whether adding to whatever we typically do that cures some but not everybody might add a few more people onto the good side of the ledger, if you will. And that's the idea of adjuvant therapy and all these new treatments that Dr. Jones mentioned. So, for example, we're in the age of discovery about, the drivers of lung cancer. So lung cancer is no longer a monolith. It is now fragmenting into tiny little bits and pieces of different biology, different behaving cancers that are driven by different gene changes and protein markers that can be identified that then allow you to attach a specific treatment to that cancer. So the Addario trial that David just mentioned started out with one of the most common targets, the EGFR mutation. But there's a myriad of other mutations. In fact, we now have 9 different types of gene mutations for which there's already been either FDA approval for 7 of them, or for 2 others very close to FDA approval, in the sense that they had something called the breakthrough designation to accelerate development. Okay. Now, these other drugs, which work against maybe somewhat less common mutations, but if you added them all up, it turns out to be a big slice of a huge pizza. We're in the process of testing them all. Now, the less common the mutation, the harder it is to do a test. But there's another mutation called the ALK mutation, for which there are trials that are testing drugs that target them. And David mentioned immunotherapy earlier. So there are also adjuvant immunotherapy trials, knowing that immunotherapy has gone through that same pattern, started out with the most difficult end of stage 4 lung cancer, tried everything, nothing really worked anymore. These drugs work. Now let's use them in first line for stage 4. Works. Now let's use them for stage 3 that can't have surgery after chemotherapy and radiation. Really works very well. Well, how about people who have surgery? Will they work? Those trials are actually still ongoing.
And Ray, I want to ask you, because historically speaking, this comprehensive biomarker testing has been talked about in the late stage patients, right? And now with sort of the findings coming out of Addario. Can you talk about what impact that's going to have on getting this testing for early stage patients? Because I know, although probably not at Baptist or at MSK, there are still places and still patients we talk to who are late stage patients who cannot get access to biomarker testing. So what is this going to mean for these early stage patients, and how do you see that sort of evolving and getting them this type of testing up front?
Yeah, I think first to reinforce the comment you made.
To Danielle's point, should we test everybody? To Danielle's point, should we test everybody diagnosed with lung cancer?
Yes. I think that's where, that's a great value, actually, the political, if you will, or the policy level value of Addario. Because one of the major problems we had with recommending routine biomarker testing was, well, how do we know who to test? Okay. The tests typically would be done through the pathologist, but the pathologist doesn't have all the information to know if this is the right guy to test or not. So early on, years ago, you would have situations where somebody has had surgery for stage 1 lung cancer, and then the pathologist, wanting to be a champ, does this biomarker testing. And then it comes to the tumor board, like, dude, why did you do that? We're not going to use it for anything. And then they get confused. So the idea of simplifying the process of testing is something that can get us from this confusing world of how do I know who to test? Therefore, I'm not testing anybody, which is unfortunately still oftentimes the case in many places, to where, well, it's almost the full spectrum now. I mean, Addario didn't include stage 1 patients deliberately because their risk for the earliest of stage 1 patients, because their risk is still small enough that it'll be hard to really prove whether or not there's benefit. But they took pretty much almost the whole spectrum of patients who undergo surgical resection. So people whose tumors were 4 centimeters or more, anybody who had any kind of invasion of critical structures like the chest wall and so on, people with lymph nodes involved. So these are the kinds of people, the kinds of people for which Addario established benefit. Now it makes our conversations within our healthcare infrastructure easier. We're now beginning to say, okay, it's good to do biomarker testing for patients who have stage 4 disease. We think it's good for patients with advanced stage 3 disease, okay, because we oftentimes will selectively treat some of those people the way we treat them, we treat stage 4. And now you have, well, even if you're going to undergo surgery, there is a role for biomarker testing. Now, I have to emphasize that right now, where we are in time, in a fast-moving world, but where we are in time, is that the one biomarker outside of a clinical trial is this specific EGFR. So I can imagine insurance companies pushing back, saying, wait a minute, you want to do this 648 gene panel when there's only one gene that we really ought to be paying for? Why would I want to do that? But you can see where the science is going. The science ultimately is going to take us to a world in which biomarker testing should be done for everyone. The technology will get to where it is cheap enough that nobody's going to be carping about the cost and so on. And I have no doubt that that's where we're going. And I think we're only a few years away from that.
I agree.
Yeah,
I agree.
I'd just make one other point. The reason to test for biomarkers that's different now than it was 20 years ago is because we can actually do something with the information. We actually have drugs, and we've done enough research, maybe not totally, to know that in treating a biomarker-driven tumor, the outcomes are better. So I think if we absolutely, ultimately will be testing all patients who have lung cancer is what I think will happen. Maybe not the very early stage ones, but everyone else is going to get tested.
That's really great. So I have one more question that I want to ask that came from the audience before we jump out sort of treatments in early stage lung cancer patients and how that they have and will continue to evolve. And then talk a little bit about how we catch more of these cancers early, right? But first, I want to get some opinions on, based on this question, on SBRT versus surgery for some of these early stage patients. And just off the top of my head, I'm kind of thinking as I'm adding to this, is there a plan to maybe add a targeted type of therapy to maybe some type of radiation therapy in the future?
Well, I can start with this. I think for those of you who don't know, SBRT is the stereotactic radiation. So it's a focused beam of radiation to the tumor and the immediate surrounding lung tissue. And typically it's delivered in about 4 to 6 treatments, more commonly. It can be a little more, but it's a little better tolerated, doesn't take as long as what's called conventional radiation. And the toxicity, if you will, to the lung is also considered to be less. So I think most radiation oncologists and thoracic surgeons would consider SBRT, for instance, for a patient who was not particularly healthy. They may have had smoked for many years, their lungs are not very strong, and they're not a good surgery candidate. In those patients, I think, would be a very good candidate for the SBRT. And some patients also just say, I'm not sure I want to get an operation, and so they would want to pursue SBRT, and I think that's totally fine. For those patients who have good lung function, are good operative candidates, have a tumor that you think you can completely remove surgically, I think the standard of care is still surgery if that's what they want to do. And I do think that just like combining drugs with surgery, there are trials going on right now combining them with SBRT just as well. So we'll learn more. And I think even more than the targeted therapy, perhaps more the immunotherapy with the radiation, I think is more likely.
Yeah, in fact, we just there are several such trials. We just opened one through SWOG, I think in 2020, trying to take advantage of what seems to be synergy between radiation and immunotherapy. It turns out when you radiate a tumor, as you damage the DNA and protein structure of the cells, they expose things that make them yummier, if you will, to the immune system, more recognizable, and the immune system is a bit more readily able to attack them. And when you add immunotherapy to that milieu, it turns out it's sort of like adding, gasoline to a flame. It allows the immune system really charge up and take over. In fact, there are this thing, the fancy awkward word called an abscopal effect that people have described, where people who get radiation therapy and then exposed to immunotherapy, they actually have apparently lesions away from the place where you radiated them actually, respond in ways that are somewhat impressive, can be impressive. So there's a lot of interest exploring the synergy between those two. Yes, exactly.
That's great. I want to jump in. I know we've got 10 or maybe 15 minutes left, if I can talk you guys into staying on a little bit longer. I want to talk about early detection in general. And one of Go-To Foundation's main goals is to increase the rate of patients diagnosed early, right? And a handful or so of years ago, we finally got some screening guidelines that looked at a very specific subset. And very recently, last week, I think, the United States Preventative Services Task Force, commonly known as the tongue twister acronym USPSTF, recently released some new guidelines. So the previous guidelines were, 55 years or older, 15, year pack history. I want to talk a little bit about the new guidelines. Actually, I want to step back for a second. The risk factors for lung cancer, there's the obvious, right? There's tobacco, and we hear about it all the time. But tobacco is not the only thing that is a risk factor for lung cancer. There's radon, there's asbestos, there's certain environmental exposures, family history, all of these things combined. So the way the screening guidelines were set up previously in the United States alone, there were roughly 10 million people walking around that qualified for this vital screening in order to try and find these lung cancers early, so that we can give them all the treatments that we've discussed in the first half of this conversation, looking for a curative effect. Can you talk a little bit about what the new guidelines are? And I want to talk a little bit about sort of the extended population that it will benefit. And I don't know who wants to take it.
Well, I can start off. So first of all, the whole idea of screening has gone through multiple iterations. First, some promising evidence, the disappointments of, trying to use chest CT scans back, in the 1970s, 3 huge trials funded by the NIH all failed. And then this idea of CT screening came about first, I believe, in Japan, and then Claudia Henschke and her group sort of ran with it, but did it in a non-comparative way. Results were pretty exciting, but there were lots of skeptics. So the NIH funded this humongous trial, 60,000 individuals, one half getting a low-dose CT scan once a year, 3 times. That's it. 3 times, and the other is getting a chest X-ray. And the bottom line, that national lung screening trial showed that, yes, indeed, screening not only saves lives by reducing your chances of dying of lung cancer, but saves lives, period, by reducing your dying of any cause. End of story. First time anybody's clinical trial has shown that for any screening test. I just want to emphasize that because low-dose screening CT sort of gets bad press sometimes. People want to focus on the harms and dangers and all kinds of stuff. But in order to be, pardon? Barney, what did you say?
I said a day in Denver.
Yeah.
A day in Denver.
Yeah. So in order to kind of give screening every chance to show its mojo, if you will, okay, they had to figure out a way to enrich for the people most likely to get lung cancer within the time that they followed them, okay? So this idea that you had to be a certain age, 55 and above, 55 to 75, I think it was, you had to have a certain intense smoking history, what we call 30-pack years, which is 1 pack a day for 30 years, half a pack a day for 60 years, 2 packs a day for 15 years, okay? And you either had to be actively smoking, or if you had quit, you could not have quit longer than 15 years ago. Otherwise, you didn't qualify for the trial. So basically, they were looking for what we would call in Texas the smokiness of the smoking population, okay? And then they put them in that trial. And when the trial was successful, the natural conservative tendency was, okay, we know this works for these kinds of people. Therefore, these are the kinds of people that we will approve to be tested, okay? That does not mean, so that's where you maybe found the light bulb. Doesn't mean that that's where you lost your keys, okay? So the problem was using those criteria, even if we found some way to get it where 100% of people who met those criteria would go through screening, we project, only find about 30% of all the lung cancers diagnosed in America every year. 70% of patients would not qualify. 70% of people destined to get lung cancer would not meet your eligibility criteria. We knew that. And so there was all this effort made to try to figure out a better way, and that work is still going on. Now, at the same time, the Europeans did their trial. They did multiple, but the real one was the Nelson trial, the Belgian trial, that used somewhat different criteria. Lower age, 50 and above, less intense smoking history, okay? And that trial came out a year or two ago and was a straight up success. Maybe even more powerful results than what we found. So grappling with this new data, the task force came up with this idea. We will lower the age from 55, the lower age from 55 to 50. We will reduce the smoking intensity required from 30 pack years to 20 pack years, okay? Now, what does that do for us? Essentially, the projections are, it actually almost doubles the number of people that will become eligible for screening. So that's the great news. Does that get us all the way? Is that the final answer? Of course not. So we still have our work cut out for us. And I'm going to pause here so David can chime in, because I would like to add one new interesting thing that we learned from World Lung just a few weeks ago from Taiwan.
Oh, good. Okay, I want to hear that.
I think you hit all the key points. I think the other thing that we've learned too in terms of specific patient populations or demographics is that women and underrepresented minorities also get lung cancer at an earlier age. And so by making it 55, we were leaving out people who probably need to be getting screened. And so the incidence, I mean, at Memorial Sloan Kettering, we are operating on more women now who have lung cancer than men, by far. So I think that that recognition was important, and to Ray's. So that would be the one thing I may add to Ray's comments.
Yeah,
I think the
that's a
same
great
is
point.
true. Sorry, I was going to say, I think the same is true in the Black population in the United States, right? Where that incidence rate lies.
Yes.
So the ability to help.
Absolutely. That was the point I was just going to reinforce, that there are two groups of people who get lung cancer with less intense exposure to tobacco. Women and racial ethnic minorities, especially Blacks. So when you set the bar at that intense 30-pack year history, what you did was you raised it too high for a lot of these folks who were going to get lung cancer anyway from smoking less than what you said was your criterion. Now, to take it all the way to the other extreme, now we know that the proportion of people who get lung cancer without personally having dragged on a cigarette themselves is rising. Okay, the lung cancer in so-called never smokers, or people who have never smoked themselves. Some of it is secondhand smoke. I worked in a bar when it was still okay to smoke indoors. I worked in a gambling establishment where we know people still smoke. Things like that. The 5 Bs of tobacco exposure, we call them: bingo parlors, bars, bowling alleys, and so on. But even then, beyond that, there are lots of other reasons why people get lung cancer. Radon gas exposure is something I think people may know, that when you buy a new house, sometimes the realtor offers you the possibility of testing for radon. Certain types of uranium miners, people who do certain types of jobs. Okay, but I'll take you to the other extreme, the talent study. Fascinating plenary session presentation. I can't wait to see the paper. So talent is the Taiwanese lung cancer screening in never smoker trial. So it's a randomized control trial that basically enrolled the photographic negative of what the NLST did. They wanted people who had either never smoked, or if they smoked, they had quit more than 15 years before. They wanted people who had a family history of lung cancer and so on and so forth. So they enriched this population, and then they did their clinical trial. And what did they find? They found a higher proportion of their screening population. I think 2.6% of their patients who had a CAT scan on the randomized trial actually turned out to get lung cancer. The NLST with this highly concentrated, for smoking population was 1.1%. Okay. Fascinating. So here you've essentially scrubbed off or really blown away, diluted the impact of smoking, which is what we always talk about. Oh, did you smoke? You got long hair. Oh, how much did you smoke? Well, here are all those people who don't smoke, never smoke, most of them. So then you begin to look at their family history. Fascinating. They found that over half of the patients with lung cancer diagnosed had a strong family history, a first, second, third degree relative. And the fascinating part was the family history was not through the dad. It was your mother, brother, or sister having had lung cancer. Suddenly your risk, went way up. So what that begins to do is it begins to guide us where to look for the gene that makes that susceptibility so, which creates the opportunity to really discover something that can help a much larger, quite frankly, much larger proportion of people.
And you know what that means is we have to stop trying to make it continually be smoking and look for new things like hormones, birth control. Why are women different than men? Because they take a lot of those things. That could be one reason. We're doing that epidemiology study for the young lung patients under 40. And we just went in for publication on our genomics of young lung. And we're asking all those questions. What's the difference between men and women? My family, 4 other members lost to lung cancer. I'm number 5. All my mother's side. So there are other reasons. And you never want to you don't want people to think you're promoting smoking, because we all know smoking is bad. It's the number 1 cause of heart disease. But there's no stigma there. And we've had things that have kept us back for so long from doing good things for lung cancer patients. And that door is wide open now. That door is wide open for us to start significantly saving some lives.
I agree. And I think, again, being mindful of time, there's 2 things I want to touch on. And if we can do it in under 5 minutes, that would be great. And then I can let everybody go. But I think they're very important, especially when we're talking about early detection as a whole, even outside of screening, as screening sits right now. And one of the things, even with the new guidelines that came out, there's going to be some challenge with coverage, right? And GoTo Foundation and the ACR recently signed a joint letter to payers urging expedited coverage for this new subset of qualified people. And that, to Dr. O's point, it almost doubles the amount of people that will qualify for this type of screening. But then outside of that, there are other areas that I think, quite honestly, we could do better, right? And one of them is incidental pulmonary nodules. I can't tell you how many times we get a phone call from a patient who's now diagnosed stage 4, and they said they saw something on a scan 3 years ago when I went into the emergency room for something. Why didn't anybody tell me? Why didn't I follow up with that? So can you guys talk a little bit about what IPNs, incidental pulmonary nodules, are and how they should be managed? Anybody?
Yeah, I can do that, and certainly do it in less than 5 minutes. I think that it's extraordinarily common. We get CAT scans for any number of reasons, some abdominal discomfort. You go to the emergency room, we often joke that you just go right through the CAT scanner to get to the emergency room. So everyone is getting them. And incidental pulmonary nodules are very common, and the majority of these nodules are benign. But in certain patients who may have some risk factors, they're a smoker. Maybe they're a woman who's not a smoker, but a strong family history, as Bonnie just talked about. I mean, those nodules need to be taken with a little bit, they need to be looked at differently. And there are guidelines. Again, Ray mentioned the Flesher Society, but this is exactly, if you have an incidental discovered pulmonary nodule, there is a protocol that you should be put on in terms of follow-up with additional imaging, typically. So I think that this is a very common problem. We get this all the time in our clinics as well. The only thing that as I've reflected on this, is having the patient get a copy of your CAT scan report and go over it with your primary care doctor and make sure that everyone's on the same page. Just getting the CAT scan and being told by someone in the emergency room or wherever that it's okay, it's probably not good enough.
Yeah.
But there are algorithms on how to manage these nodules.
And I'll just chime in that that's a real opportunity. So in my healthcare system, years ago when we started our multi-D program, where the radiologists and everybody else would be gathered in a conference room together, I think they became quickly aghast at how many times we could trace the natural history of undiagnosed lung cancer. And I think the moment of crisis came about when the guy who was chief of radiology saw the thing and traced him. I was like, yeah, and then he looked at the report, and it was his report. He had dictated several years before, lesion, recommended CAT scan in 3 months, never got done. The guy had a heart attack. Everybody was excited about taking care of his heart attack. He survived it, only to run into stage 4 lung cancer 3-4 years later. So after that, we started this effort to organize how we triage these CT scans using technology. We use our electronic health record system, have a macro text that the radiologist is asked to put in there that automates the collection, and then we have a team of navigators using guidelines to triage them into different risk categories. I'll tell you, fast forward, we started our screening program and this incidental lung nodule program about the same year, 2015. You fast forward 2020, for every one lung cancer we have diagnosed through screening, we have identified 6 patients with lung cancer. The ratio is 6-to-1. It's incredible. And what is really fascinating is, once again, almost 70% of the patients we diagnose with lung cancer through the nodule program, 70% of them would not have been eligible for screening using the previous criteria. So a huge opportunity. And one of the things we're saying is we probably need to implement these programs in tandem, because there's great synergy between them.
Right. Exactly.
Yeah, I think that's a great point. And I know, Ray, you and your colleagues in Baptist are part of our Center of Excellence network and our Excellence in Screening and Care network across the country. We're really starting to have these big conversations about those who don't have, good workflow plans around their incidentals. What does that look like, and how can we help them implement them so that we can get the ball rolling in a way bigger way there. The last thing I'm just going to touch on before we close out, and the third thing that we are looking at is some of the blood-based diagnostics that are coming out to find cancers early in the blood before before a patient even has some sort of an imaging diagnostic, and those things are coming. They're on the horizon, and I wish we had more time to kind of dig into some of that and what that might look like. But it gives you an idea, this conversation, I think, for everybody watching tonight and those that will go back and watch post-live, about some of the great work that's happening in lung cancer, the great work that's happening out at Memorial Sloan Kettering, out in Memphis at Baptist, and many, many, many other places around the country. It's a fast and furious world, this space of lung cancer diagnostics and treatment right now. And although it's never exciting to have a diagnosis, the options for patients are growing more and more. So, with that, we of course need to, continue to advance research and federal funding in the areas of early detection, such as some of the work being done in this blood-based stuff. Bonnie touched a little bit on epidemiology and what we might learn and find, commonalities we might find in talking with patients about that sort of thing. And, enable us to widen that net on the number of people that we can diagnose at an early stage when the cancer is most curable. So with that, I'm going to say thank you to our panelists for this conversation tonight. I genuinely hope, and fingers crossed, that once this pandemic sort of runs its course and we are all able to get back together live, that you will come and join us out here in California in the living room. And do this again sometime soon. So thank you all very much. I'm going to do a little bit of housekeeping before we finally close out for the night. First, I want to remind everybody about Bonnie's book, The Living Room, A Lung Cancer Community of Courage, which is currently available for pre-order. You can find information on Amazon, Barnes & Noble, or of course on our website. The hard copy will be available May 4th. So stay tuned for some news and some exciting sort of activities to be happening around the launch of that book as well, particularly in the living room community. Our next living room is actually next week during our 2021 Voices Summit. We have Dr. Harpreet Singh from the FDA, Dr. John Minna from UT Southwestern, our very own Amy Moore, and Johanna Ralston, who's a go-to board member and has done a lot of work in public health. We're going to be talking about COVID and lung cancer, everything from all of the silver linings, which Bonnie kind of touched on before, and the things that did continue to happen in spite of the pandemic, as well as, moving forward through some of the research that GoTo is involved in looking at COVID and lung cancer. So stay tuned for that. And then our next regularly scheduled living room is April 20th. Dr. Roy Herbst from Yale, who has been a speaker here with us before, so I'm sure you guys will remember him, is going to be talking about personalized medicine, diagnostics, and treatment. So a little bit deeper dive into what we were already talking about tonight, where patients are individuals and should be treated as such. So keep on the lookout for that. Events, as most of you know, our spring Step into Spring virtual step challenge is this Saturday. So if you haven't signed up and you're interested in signing up, please do so. And our registration is also open for our second annual Summer Jam, our virtual 5K Your Way, which will be on June 26th. If you're an endurance athlete, a lot of that is opening back up too. So please go to our website to go to the Get Involved tab and check it out to see where you might find interest there. Our lung cancer registry, I always want to push that because patient-reported outcomes and the information we're gathering there is vital and is a sort of a missing piece in a lot of the research that's currently being done. So please consider joining our registry and sharing your information. Again, thank you to our panelists, Dr. O, Bonnie. I see you still sitting over there. Dr. Jones, this is your first time in the living room, but I'm so excited to have had you and for Ray's recommendation. I think this has been a spectacular evening. I'm going to end with a final thank you to our supporters. Without their help, we simply couldn't bring this vital information to you every month. So Oncocyte, who's our topic sponsor this evening, Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly Oncology, Merck, Novartis, Regeneron, Sanofi, and Takeda. A huge thank you to all of you for your support and your belief in the content that we are bringing out to our patient community every month. Thank you all. Have a wonderful night, and I apologize we went a little late. See you next time.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.